for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request Professor Dr. Rupa Mehta to start this session. Welcome, ma'am. Over to you.
Yeah. Good evening, sir. Good evening to all trainees. So today we'll be covering a very interesting and a very vast topic, actually, surgical anatomy of neck. All of us sees neck surgeries day in and day out. So warm greetings from AIMS Raipur. So as we all know, neck is a very compact conduit of very vital structures. A lot of variety of tissues are present in neck. You have pharynx, larynx, neck nodes. Out of 800 neck nodes in the human body, almost more than 200, almost in the between 200 to 300 nodes are there in neck. And submandibular gland, parotid tail, okay, thyroid, parathyroid gland, blood vessels, big blood vessels, carotids, IJB. So nerves, the cranial nerves, and the cervical plexus, brachial plexus, and cervical spine and its associated musculature. So it's a very, very compact conduit in which all these structures are very tightly packed. Okay, and it joins the head to the trunk. And a lot of structures you can palpate and visualize, like feel for yourself. Like you have hyoid, thyroid cartilage, thyroid gland, trachea. The vessels can be palpated. The carotid pulsations, the IJB, EJB can be seen. So neck, because of multiple structures packed tightly, there are myriad of pathologies which we see in neck. They can range from benign to malignant, congenital to acquired, and as we know, these can be derived from various tissue types. And there are a vast variety of neck surgeries, right from small procedure like tracheostomy, which is a life-saving procedure, to extensive neck dissections, laryngectomies, thyroidectomies, okay, excision of parathyroid glands, the submandibular gland, carotid body tumors, etc. So there are a lot of surgeries which happen in neck. And so are the associated complications and sequelae, which can range from minor, problems like hypertrophic scars to deadly complications like carotid artery rupture and excessive bleeding. So that is why we need to be very, very aware and recognize the various anatomical nuances of neck. Okay, so today we'll be discussing. As I told you, it's a very vast topic. So we'll be discussing in nutshell an overview of neck. So neck has a very layered anatomy. Okay, so you have skin, subcutaneous tissue, and platysma. Then you have cervical fascia, the muscles, the glands, and the lymph nodes. Glands can be endocrine glands like thyroid, parathyroid, and submandibular, salivary glands, submandibular, parotid tail, etc. Then you have visceral, larynx and trachea, pharynx and cervical esophagus, vessels and nerves, thoracic duct and lymphatic duct on the right side, vertebral column and surrounding musculature. So as I told you, a lot of surgery is being performed. So neck incisions are planned in such a way that they correspond to the skin tension lines, so that optimal scar formation and minimal wound contraction occurs. Okay, now blood supply of skin of neck is derived from facial, occipital, posterior auricular, and subclavian arteries branches. And they form a rich network within platysma and in subdermal plexus, which accounts for viability of various skin flaps raised during neck dissections and neck surgeries. So as you can see in this picture, from the occipital artery, from the facial artery, from the posterior auricular artery, from the transverse cervical, from the superior thyroid artery, the various branches innervate, supplies blood supply to the skin of the neck. And this is the watershed area. So that is why the skin incisions are planned in such a way that don't interrupt the vasculature. If you plan the skin incision slightly down, or you interrupt the incision interrupts the supply, then you can have necrosis of the skin flap. Okay, so venous drainage of skin of neck mirrors the arterial supply, and veins drain into jugular and facial veins. Now, platysma is as we all know, we always on all surgeries we read subplatysmal flap. So platysma is a broad sheet of muscle which arises from fascia covering the upper parts of pectoralis major and deltoid muscles. The fibers ascend over the clavicle and on the neck and reach the mandible and the lips. Okay, and the careful elevation of all surgeries raise a subplatysmal flap so as to with its blood supply, so as to minimize the risk of skin necrosis and wound breakdown. Platysma, the blood supply is by the submental branch of facial artery and by suprascapular artery from thyrocervical trunk of subclavian artery. The nerve innervation is from the cervical branch of facial nerve, as we all know. and it descends on the deep surface of muscle close to the angle of mandible. Now its action is when it contracts, it diminishes concavity between jaw and side of neck and produces tense oblique ridges in the skin of neck. And facial plastic surgeries in aging, those platysma bands happen. So a lot of facial plastic surgery does revolve around platysma and platysma in the neck. And even you have platysma flaps. Okay, so platysma assists in depressing mandible, and via its labial and modular attachments, it can draw down the lower lip and corners of the mouth in expressions of horror and surprise. So in this action is by the action of platysma. Now, cervical fascia, very important entity. Like cervical fascia is it compartmentalizes structures within neck. Because of this, all the structures are contained in such a compact conduit so well. So this is a very tough fascia which limits spread of infection. Okay, so those various layers, they bind the tissues, and they also enclose the potential spaces between them. So if any infection happens, they have a well-defined spread, and the deep neck spaces are named accordingly. This is beyond the scope of today's class, but yeah, deep neck spaces is a very important topic on its own, and it's a big topic on its own. So cervical fascia has superficial and deep layers. Okay. Now superficial cervical fascia contains platysma, cutaneous nerves from cervical plexus, superficial vessels, and lymph nodes. Now deep cervical fascia is further divided into three. That is deep investing fascia, the middle layer, and the deep layer. So the investing fascia, or the superficial layer of deep cervical fascia, encircles neck and splits to enclose sternocleidomastoid and trapezius muscles, forms roof of anterior and posterior triangles of neck. The pretracheal fascia, the middle layer, forms a tubular sheath in anterior part of neck and extends from hyoid to blend with into the thorax to blend with fibrous pericardium. It contains thyroid gland, parathyroid glands, and buccopharyngeal and esophagus. And buccopharyngeal fascia is the superior and posterior most part of the pretracheal fascia. So see, this is the way it is shown. These are the rule of two for investing layer of deep cervical fascia is that it encloses two muscles, that is sternocleidomastoid and trapezius, two glands, submandibular and parotid. So now pretracheal fascia is again very important when we do thyroid surgeries and all. Then prevertebral fascia forms a tubular sheath around vertebral column and forms floor of posterior triangle of neck. It is also the posterior limit of neck dissection. Okay. It contains the sympathetic trunk, phrenic nerve, brachial plexus, cervical vertebrae, and paravertebral muscles. LR fascia is one of the layers of, that is the anterior lamina of prevertebral fascia has two layers. Anterior layer is referred to as LR fascia. Now, axillary sheath, the prevertebral fascia extends laterally as the axillary sheath, which surrounds the axillary vessels and brachial plexus. Now, carotid sheath, which contains the common and internal and external carotids and internal jugular vein, vagus nerve, derives its components from all three layers of deep cervical fascia. Now, muscles. A lot of muscles are there in neck, in the anterior neck, in the lateral neck, in the posterior neck. So muscles of neck are also grouped with the layers of cervical fascia. For example, platysma invest with the superficial fascia. Then sternocleidomastoid and trapezius are located within the investing layer of deep cervical fascia. Suprahyoid muscles are deep to investing fascia. Infrahyoid muscles are within the pretracheal fascia. Vertebral muscles are located within prevertebral fascia. So it lends a very, like wherever we operate, we find that facial layers make the surgery very easy. You have a, like a defined route and defined way of doing things. It all happens because of the facial arrangements. Okay. Now, sternocleidomastoid is one of the major muscles in the neck. It protects your carotids. Okay, it is the nature's protection to the carotids. Okay, whenever nowadays radical neck dissection does not happen so frequently, but during the olden days when radical neck dissection, if you see the neck of radical neck dissection with the sternocleidomastoid removed as well, you can you can feel the carotid, you can see the carotids, and it is so very well, so very exposed. So sternocleidomastoid tends to protect the vital structures. So it originates from manubrium and medial aspect of clavicle and inserts onto the mastoid process in superior nuchal line, supplied by the occipital artery and superior thyroid artery. The actions are to flex the neck, extend the neck, and rotate the head to the opposite side. Then also an accessory muscle of inspiration, and it is the motor innervation is by accessory nerve, that is spinal accessory cranial nerve 11, and cervical plexus. Provide the sensory innervation. Now, trapezius originates in occipital protuberance and medial superior nucleus and attaches at lateral third of clavicle, acromion process, and spinous processes of C7 and T12. It's a very large quadrilateral muscle, okay, and is in relation with the neck posteriorly, okay, back, upper back, and posterior neck. It forms the, sternocleidomastoid and trapezius enclose the posterior triangle of the neck. Now, what is the function? As we all know, we routinely check the shrugging the shoulders, rotation, depression, and retraction of the scapulae. Motor component is again by spinal accessory nerve, and few components, minor components also derived by cervical spinal nerves C3 and C4. Now, main artery is the superficial branch of transverse cervical artery, at times superficial cervical artery, or this directly from subclavian artery. Now, the suprahyoid muscles, that is the muscles which attach the hyoid bone to the mandible, suprahyoid, and infrahyoid, that is how we divide. Now, suprahyoid is, there are 4 muscles, okay, they help in swallowing and vocalizing. And, hyoid is a peculiar bone that it is not connected to any other bone in the body, okay, and it is suspended by muscles and ligaments. So, that is how we divide the muscles into suprahyoid and infrahyoid. So, the 4 suprahyoid muscles are digastric, geniohyoid, mylohyoid, and stylohyoid. And infrahyoid muscles fix the hyoid bone from below, allowing suprahyoid muscles to act. So, the infrahyoid muscles are omohyoid, sternohyoid, thyrohyoid, and sternothyroid. Omohyoid and sternohyoid are superficial, and thyrohyoid and sternothyroid are deeper to those 2 muscles. All of them are supplied by ansa cervicalis. Now, the pharyngeal constrictors. There are 3 pairs of pharyngeal constrictors which encircle the pharynx, forming a muscular funnel. And during swallowing, they drive the food into the esophagus. All pharyngeal constrictors are innervated by the 10th cranial nerve. Now, the muscles acting on head. Okay, those are the muscles which originate from or have origin from the vertebral column, thoracic cage, and pectoral girdle, and insert on the cranial bones. Their action is flexion, extension, lateral flexion, or rotation of the head and neck. So they may cause contralateral movement, that is movement of head towards opposite side or towards the ipsilateral side. Neck flexors are sternocleidomastoid and scalenes, that is anterior, posterior, middle scalenes, and neck extensors are trapezius, splenius capitis, and semispinalis capitis. So you can see in the floor of the posterior triangle, if you go from above down, you have semispinalis capitis, you have splenius capitis, levator scapulae, and scalenus medius, anticus, and posticus. Okay, and this is the trapezius, this is the sternocleidomastoid, this is the posterior triangle. Now, posterior cervical muscles, which are mainly involved in, these tension headaches and all also. So, 3 main groups of cervical muscles that form a sleeve around vertebral column and enable control of posture and segmental movements. So, these include deep cervical flexors, that is longus colli and longus capitis, deep neck extensors, which are semispinalis, and suboccipital muscles, which are rectus capitis posterior, major, minor, and obliquus capitis superior and inferior. So, these are the various muscles. Now, coming to cervical lymph nodes. Now, as we all know, cervical lymph nodes, we have a lot of pathology. These get enlarged due to multiple reasons, due to infective pathology, due to malignant pathology. Okay, so Rouvier classified cervical nodes into a collar of nodes surrounding upper aerodigestive tract and 2 groups along the long axis of neck. So the collar of nodes, the circular, the system which he described was submental, facial, submandibular, parotid, mastoid, occipital, and retropharyngeal. And along the long axis, you had anterior cervical and posterolateral cervical. However, nowadays, what the system which is being used is by memory, which is being put forward by MSKCC New York, which is simpler and more, it is in concordance with the neck dissection which we do. So level, it is divided into level 1 to 7. 1A and 1 is further divided into 1A, 1B, 2 is also further divided into 2A, 2B, then 5 is divided into 5A, 5B. So you have submental lymph nodes, submandibular lymph nodes, 1A, 1B, 2 is internal jugular from the base of skull to the inferior border of hyoid bone, 3 is from the hyoid to the cricoid, 4th is from the cricoid to the supraclavicular fossa, 5th is the posterior triangle or spinal accessory nodes, 6th is the central compartment nodes, that is from the hyoid to the suprasternal notch, mainly involved in thyroid carcinomas. Okay, then you have 7th nodes, which are the superior mediastinal nodes. Now, American Academy does not include 7th as in the cervical node system classification, because that is considered as mediastinal lymph nodes, and therefore not related to the neck, but in the routine classification, in the classification given by MSKCC, it is 1 to 7. Now, just a brief mention about root of neck. The thoracic inlet, okay, or the superior neck aperture, through which these structures, the brachiocephalic trunk, the subclavian artery and its branches, subclavian vein, internal jugular vein, distal part, thoracic duct, apex of lung, phrenic nerve, vagus nerve, these all traverse in the root of neck. Now, the visceral layer we said, it has 3 layers: an endocrine layer, that is the thyroid and the parathyroid glands, a respiratory layer, trachea and larynx, alimentary layer, pharynx and esophagus. Now, each of these is a class in itself. So, I'll be just, providing you an overview of all these, and then we'll be discussing the pertinent points. So, pharynx and cervical esophagus. So, pharynx is a funnel-shaped fibromuscular tube that extends from base of skull to cricoid cartilage, where it continues as cervical esophagus. Now, we all know pharynx is divided into nasopharynx, oropharynx, and hypopharynx. Hypopharynx comes in relation with the neck. It has 3 parts: your pyriform sinuses, then your postcricoid, and the posterior pharyngeal wall. Then it continues into the cervical esophagus. Larynx, as we all know, is a fibromuscular cartilaginous structure, formed with a lot of paired and unpaired cartilages, connected by ligaments and muscles, and it is continuous with laryngopharynx superiorly and trachea inferiorly, and provides an open airway. Okay, so now blood vessels. The major arteries are subclavian and common carotid arteries and their branches, which provide most of the blood supply to head and neck. Okay, internal carotid artery, as we all know, does not have any branch in the neck, so that is the main supply to the head. But subclavian and common carotid have a lot of branches which supply the various parts of the neck. Now, external and anterior jugular vein are principal venous return for the neck. Internal jugular vein provides venous return for the head. Okay, so you can see in this diagram the various vessels, the internal jugular vein and its tributaries. Okay, then you have the carotids, the various tributary, the branches. Okay, this is the larynx, the thyroid gland, the various muscles. Now, the subclavian artery, if you see from the right side, on the right side, it arises from the brachiocephalic trunk. On the left side, it arises from the arch of aorta directly. Now, it is divided into 3 parts by scalenus anterior muscle. Okay, the first part is medial to the muscle, and it gives 3 branches: vertebral artery, which enters the foramen transverse area C6 and travels upward and reaches the brain and helps in the formation of basilar artery and the circle of Willis. Then thyrocervical trunk, which gives various branches in the neck: inferior thyroid, transverse cervical, and suprascapular arteries. Internal thoracic artery. Part 2 is posterior to the muscle and gives the branch costocervical trunk, which further divides into superior intercostal and deep cervical arteries. And part 3 is lateral to the muscle, which gives dorsal scapular artery, at times suprascapular artery. Now, the branches of thyrocervical trunk. You have the inferior thyroid artery. This is the inferior thyroid artery, which also gives a branch, that is the ascending cervical artery, which supplies the prevertebral muscles. Inferior thyroid artery supplies the thyroid, and the parathyroids. Okay, then the transverse cervical artery. This is the transverse cervical artery. It crosses base of carotid triangle and supplies the trapezius and the rhomboid muscles. See, you can see here. Then suprascapular artery, which is this portion, it supplies the posterior shoulder area. So these are the branches of thyrocervical trunk. Now, external carotid artery, as we all know, begins at the level of carotid bifurcation and traverses the neck and ends within the parotid gland by dividing into superficial temporal artery and maxillary artery. Now, it has 6 branches: superior thyroid artery, lingual artery, facial artery, ascending pharyngeal, occipital, and posterior auricular arteries. Now, various veins, form a network, form a plexus within the neck, which we shall study. Now, this is a very simplified diagram of how the IJV and its tributaries are formed, and how the EJV and its tributaries are formed. So, see, if you see superficial temporal and maxillary, these 2 divisions combine and form the retromandibular, which further divides into anterior and posterior. The anterior part of retromandibular vein combines with the facial and forms the common facial vein, which drains into the IJV. Now, the posterior branch of the retromandibular vein combines with the posterior auricular artery and forms the external jugular vein, which also receives few tributaries: posterior external jugular and transverse cervical, and ultimately drains, and also the anterior jugular. Anterior jugular we'll call later. It is paired, anterior jugular here, and here you have 2 anterior jugulars, which also form a jugular venous arch, which you can see here. Anterior jugular also drains finally into EJV, and both of which drain into the subclavian. So these are the various veins of the neck. Now, brachial plexus, a network of nerve fibers that supply skin and muscles of the upper limb. Yeah. Please let me know if if the voice is not clear. Yeah. So brachial plexus, a network of nerve fibers that supply skin and muscles of the upper limb. Now it begins in the root of neck, passes through axilla and runs through upper extremity. It is formed by anterior MI of cervical spinal nerve C5 to C8 and T1. Now roots converge to form trunks. 3 trunks are there, superior, middle and inferior, which traverse laterally, crossing posterior triangle of neck, and then they further divide into divisions, which leave the posterior triangle and pass into axilla. So this is how it is, these brachial plexus, the various roots and the trunks and the divisions traverse from the posterior part of the neck to the axilla and the upper limb. So this is how the various roots are seen. Now cervical plexus, it is located in posterior triangle of neck, almost midway up till the sternocleidomastoid and within the prevertebral layer of cervical fascia. It is formed by anterior MI of C1 to C4. Okay, so now this is how the roots, the C1, C2, C3, C4 and C5. Okay, so you have the various sensory divisions, greater auricular, C1, C2, C3, then lesser occipital, transverse cervical and supraclavicular nerves. Then C3, C4, C5 forming the phrenic nerve. Okay, a part of a twig from the C1 travels with the hypoglossal nerve, which supplies the genohyoid and thyrohyoid. And C1 and C2, the twigs form they combine and form the insa cervicalis in front of the internal jugular and supply the infrahyoid muscles. There are various other muscular branches of the cervical plexus which supply the posterior cervical muscles like rectus capitis, anterior and lateralis, longus capitis, sternocleidomastoid, prevertebral muscles, levator, scapulae, scaleni, and trapezius. A cervical plexus block, all of you must have seen, anesthetists give cervical spinal plexus block at the Erb's point in neck surgeries, and they infiltrate, local anesthetic at the Erb's point, superiorly, anteriorly, and inferiorly, and then it provides block of the cervical plexus, and for the surgery they do routinely. But as this can also affect the phrenic nerve, so it is not usually performed on those with existing cardiac or respiratory disease, because phrenic nerve supplies the diaphragm. So this is ansa cervicalis. I already mentioned it to you. C1 twig, which is traveling with the hypoglossal nerve, and C2, both of them form an arch above the internal jugular vein and the carotid, and they supply the various infrahyoid and infrahyoid muscles, omohyoid, sternothyroid, sternohyoid, omohyoid. Okay. Now phrenic nerve. Now phrenic nerve, as we all know, has C3, C4, C5. Okay, it is formed from C3, C4, C5 roots, and it is in relation with the scalene muscles. Okay, lies deep to prevertebral fascia and runs posterior to subclavian vein. And then right and left, there's little right and left phrenic nerve. There's little difference. The right phrenic nerve will pass anteriorly over lateral part of right subclavian artery, and left phrenic nerve passes over medial part of left subclavian artery. Then they both of them enter through the root of neck into the thorax and descend anteriorly along their respective lung roots. And left will cross the aortic arch and the bypass vagus nerve and course along the pericardium to supply the inferior part of diaphragm. Right will course along the pericardium of right atrium and pierce the diaphragm at the inferior vena cava opening and supply the inferior diaphragm. Now cervical sympathetic trunk. The sympathetic supply in the neck, mainly, it hitchhikes around the arteries. Okay, like the internal carotid arteries and multiple arteries, and there are 3 ganglia: superior cervical, middle cervical, and inferior cervical ganglia. Now middle cervical at times is absent. Inferior also at times joins with the first thoracic to form cervicothoracic ganglia. And then here the sympathetic fibers form synapses here, and the postganglionic sympathetic fibers supply the various glands. And injury to the cervical sympathetic nerve, as we all know, leads to classical Horner syndrome. Now vagus nerve is a very long nerve which traverses through almost the entire neck and the entire torso, entire body. So it branches within the neck the pharyngeal branches, the superior laryngeal nerve, the recurrent laryngeal nerve, the superior cardiac nerves. Okay, and it innervates the striated muscles of larynx and pharynx, except the stylopharyngeus, which is supplied by the ninth nerve, and the tensor villi palatini, which is supplied by the fifth nerve, the third branch. And it innervates palatoglossus muscle. External branch of the superior laryngeal nerve supplies the cricothyroid muscle. Okay, and the recurrent laryngeal nerve supplies all intrinsic muscles of larynx except the cricothyroid, and it also supplies the sensory innervation to the subglottis. The pharyngeal branches of vagus supply the levator villi palatini, salpingopharyngeus, palatopharyngeus, and uvula. Now, spinal accessory nerve, one of the very, very important nerves to identify and to protect in the neck dissections. Okay, especially when we are doing level 2 and level 5 neck dissections. So it descends along the carotid artery to reach the sternocleidomastoid, which it innervates, and then exits it at the junction of upper 1/3 and lower 2/3, and runs along the roof of this posterior triangle, and then enters the trapezius at the junction of upper 2/3 and lower 1/3. Okay, so extracranial course of the spinal accessory nerve is relatively superficial. It runs between investing and prevertebral layers, and therefore is vulnerable to damage, especially so in fifth level 5 dissection. Now, hypoglossal nerve, it exits the cranium by the hypoglossal canal and receives a branch, as we saw from C1, which just travels through it, does not just merely travels within its sheath, and then it then passes inferiorly along the angle of mandible, crossing the internal and external carotid arteries, and then above the digastric tendon, okay, and moving it in anterior direction to enter the tongue. So this we routinely see in some mandibular gland excisions, the hypoglossal nerve with its vena comitans lying just above the common digastric tendon. Okay. So then recurrent laryngeal nerve, very, very important nerve to save during thyroid surgeries. Left and right, the origin is slightly different. The left hooks around the arch of aorta, right side along the subclavian artery, and both of them travel in the T groove, that is the tracheoesophageal groove, to enter through at the cricothyroid joint. Okay, so the obliquity, the superficiality is different, and there are multiple landmarks we know during thyroid surgeries through which we identify multiple triangles which have been defined, through which we identify the recurrent laryngeal nerves. Okay, and the parathyroids also have a very, very constant relationship with the recurrent laryngeal nerve, inferior being anterior to the recurrent inferior parathyroid gland being anterior to the recurrent laryngeal nerve, and superior being posterior to the recurrent laryngeal nerve. So at the point where it enters, it is known as the RLN becomes the inferior laryngeal nerve. An inferior laryngeal branch of recurrent laryngeal nerve innervates all intrinsic muscles of larynx, excluding the cricothyroid. Okay. Now, thoracic duct. Thoracic duct, you can see it originates from the cisterna chyli, on the lumbar vertebra, and it receives, like from the abdomen also, it receives the lumbar lymphatic trunks and all. Continues cephalad and passes through the aortic hiatus of the diaphragm into posterior mediastinum between aorta and azygos vein until the level of T5, where it passes behind esophagus. Okay, and lower down it has biductal or plexiform structure, but as it continues forward, as it continues cephalad, it becomes a single 2 to 3 mm duct, above 2 to 3 mm duct, and it continues adjacent esophagus, passing posterior to aortic arch and left subclavian artery, then arches over, it arches over the subclavian and the IJB and drains into this to empty either single or multiple lymphatic channels into left subclavian vein near its confluence with the left internal jugular vein. And there's a one-way valve which prevents the blood from entering the thoracic duct. Right lymphatic duct is also there, which drains into the right subclavian. This is right right lymphatic duct which drains into the right subclavian. So this is how from behind it comes and hooks around and drains at the confluence of the IJB and the subclavian. So this is the thoracic duct. This is very, very important, especially when you're doing left side neck dissection injury to thoracic duct occurs, and then you have chyle leak, and if it should be identified intraoperatively, and then it can be oversewn so that post-operatively the chyle leak and does not happen. But if it is not identified intraoperatively, then postoperatively you will see that drain, there'll be a lot of drain, like collection in the drain of milky fluid. And then you take measures, conservative measures, and then if it does not heal with that, then you have to resort to surgery. Now triangles in neck. And neck has been is one structure which has been divided into triangles to facilitate the understanding and the nomenclature of the various structures. So you have anterior and posterior triangle of the neck, which is defined by the sternocleidomastoid. So sternocleidomastoid divides neck into anterior and posterior. So the anterior neck and the anterior triangle and the posterior triangle. So anterior triangle is bounded by the middle of the neck, anterior border of sternocleidomastoid, and inferior border of mandible. Okay, and the midline. Okay, so it is subdivided into 3 paired and 1 unpaired triangle. So unpaired is the submental triangle, and 3 paired are the submandibular, the carotid, and the muscular triangles. Okay, so you can see this is the submental, which is the unpaired, level 1A, then submandibular, then this is your carotid, muscular. Okay, so all these form the anterior triangle. So this is the anterior triangle of the neck. Okay, mandible, sternocleidomastoid, midline. Okay, yeah. So submental is the unpaired triangle bounded by anterior bellies of both digastric muscles and body of hyoid bone. Its floor consists of mylohyoid muscle. It contains submental lymph nodes and also small veins and isthmus in this triangle to form the anterior jugular vein. Now, submandibular triangle is bounded by anterior and posterior bellies of digastric muscle and inferior border of mandible. Floor is formed by the mylohyoid muscle. Okay, and it contains the submandibular gland with its associated nodes of star, the vessels, the facial vessels, the lingual arteries, veins, submandibular glands, lymph nodes, nerve to mylohyoid, hypoglossal nerve, marginal mandibular nerve. And 3 small triangles are included inside submandibular triangle, which are Lessers, Pirogov's, and Becklard's. Initially, these nomenclatures were used. Nowadays, they are not. They have fallen into disrepute. But they were basically used to identify the structures like lingual artery, okay, and common carotid Pirogov's and all. So, but nowadays they are not. These nomenclatures are not being used. Now, carotid triangle is bordered by posterior belly of digastric, superior belly of omohyoid, and anterior border of SCM. So, see, this is your posterior belly of digastric. Then this is superior belly of omohyoid and sternocleidomastoid. Okay, floor and medial wall is formed by hyoglossus, thyrohyoid, inferior and middle pharyngeal constrictor muscles. Now it includes common carotid artery and its bifurcation, superior thyroid, lingual, its bifurcation and its ECA branches, like superior thyroid, lingual, facial, occipital, nasal pharyngeal arteries, accompanying wings. The nerve, as we saw, hypoglossal nerve traverses through that. So hypoglossal nerve, external internal branches of superior laryngeal nerve arising from the vagus nerve. So it's a very, very important triangle actually. And Pirogov's triangle is a it's defined by the common facial vein and the IJV and all, and it delineates your common carotid. So these nomenclatures are not being used, the Pirogov's, the Becklard's and all. But this is the standard, the routine classification which is being followed, carotid, the anterior and posterior divisions. So the muscular triangle is bounded by the midline of the neck, okay, anterior margin of sternocleidomastoid and superior belly of omohyoid. Okay, so you can see the muscular triangle here, the superior belly of omohyoid, the sternocleidomastoid and the midline of neck. Includes the strap muscles, the anterior jugular and inferior thyroid veins, ansa cervicalis, and superior thyroid artery branch, and contains various lymph nodes, the pretracheal, the paratracheal, the prelaryngeal, anterior cervical, infrahyoid, and medial part includes esophagus, trachea, thyroid gland, and lower part of larynx. Now, posterior triangle of neck, as we all know, the boundaries are posterior border of sternocleidomastoid, anterior border of trapezius, and mid 1/3 of clavicle. Shape is spiral. Roof is formed by the investing fascia, platysma, external jugular vein. Floor is the prevertebral fascia covering muscles. We saw the various muscles forming the floor, semispinalis, capitis, and all the other muscles, levator, scalene. Okay. So subclavian artery, trunks of brachial plexus and cervical plexus. Contents are the arteries, occipital, superficial cervical, suprascapular. Veins, transverse cervical, suprascapular, external jugular. Nerves, the branches of cervical plexus, 11th nerve, omohyoid. Then lymph nodes, occipital and supraclavicular. So this is the diagram showing the contents and the boundaries of the level 5, that is the posterior triangle. sternomastoid, trapezius. Okay, these are the various muscles: semispinalis capitis, splenius capitis, levator, scalenii. Okay, this is the clavicle, the mid-third part. These are the various nerves, the arteries which go through that. Three arteries, basically: occipital artery. And then this is the superficial transverse cervical and the subclavian artery and supraclavicular artery. Okay, and these are the various veins, EGV. These are the various cervicals, the 11th nerve and the cervical roots. Okay, and the brachial plexus roots. Now, occipital triangle. The posterior triangle is further divided by the omohyoid into the occipital triangle and the subclavian triangle. Okay, so this is the occipital triangle, the upper part. Its floor consists of levator scapulae. We saw all the muscles which form here. The floor, accessory nerve runs over it. Cutaneous and muscular branches, cervical plexus, and the various arteries, the transverse cervical artery. Okay, and then various nodes. Okay. Now the subclavian triangle corresponds to the supraclavicular fossa region. Okay. Now it contains subclavian artery, vein, and brachial plexus. The suprascapular vessels and dorsal scapular artery run transversely across the triangle, and EJB runs behind posterior border of SCM to end in the subclavian vein. Phrenic nerve exists on the anterior surface of anterior scalene muscles. So any questions? I'll be very happy to take. I wish you all a deep understanding of the subjects, and I'll convey my special gratitude to our director, sir, who happens to be an excellent head and neck surgeon, Professor Dr. Nitin M. Nagarkar, sir. And with that, I'll take any questions if there are any. I'll just stop sharing. Oh no, I shouldn't have done stop sharing. No, I have to check the. Just a minute. Yeah, question and answers or chat. Yeah. Any questions? Any questions? I'll be more than happy to take. Please write down, or if there are any questions, actually. In my chat box or question and answer box, it is not, there's no question which is being shown, maybe because I stopped and again reshared. So I don't know. If there are any questions, please let me know.
Good evening, Dr. Rupa. Can you hear me?
Good evening, ma'am. Yeah, sure.
Yeah, hi, I am Dr. Nilima this side.
Yeah, good evening.
Yeah, thank you so much for the excellent presentation. It's a very theoretical topic, but a very important one.
Yeah.
And I think there was excellent attendance, I think, for the lecture.
Yeah.
For the chat, for the questions,
Yeah.
I'll just check. Can you see the chat box?
Yeah. One question is there. Could you please explain the course of thoracic duct? And second is, please show the slides before sternocleidomastoid. So I'll try to do both if possible. Yeah. So see, the thoracic duct is, it originates in the abdomen. Okay. Cisterna chyli is there. And from that, it originates and traverses through the diaphragm. Okay. At that level of T5, it becomes posterior. And then it, ascends in the neck and ends at the junction of the IJV and subclavian vein. Okay. So I'll just show you the diagram if I can. Just a minute. This diagram, if you see.
Yes, we can see. Click on the slideshow.
Yeah, I'll do a slideshow and show. Yeah, that will be better. From current slide. Yeah. So see, right side you have right lymphatic duct, left side you have left thoracic duct. Okay, so it ascends from this cisterna chyli. This is the cisterna chyli, anterior to the L1, L2. Okay, and receives drainage from the intestinal and two lumbar lymphatic ducts. Okay, passes through the aortic opening in the diaphragm into the posterior mediastinum between the aorta and the azygos vein. Okay, until the level of T5, where it becomes more posterior and passes behind the esophagus. Okay, until that level, it is either two or plexiform appearance, like either there are two ducts parallel going or there are plexiform appearances there. As it ascends, it becomes a single small duct, 2 to 3 mm. Okay, and it continues adjacent to the esophagus to rise at the root of neck and to end at the confluence of the IJV and the subclavian. So it is a very thin walled structure. I hope that solves your query. I can also show the next slide. Wait a minute. This will further clarify the neck portion nicely. See how it traverses and opens into this. But multiple, it is not that it will open by a single this thing. There are multiple ductules. By multiple openings it opens. Yeah, and someone wanted to see the slides before this, no? So I'll just see if I can show before the sternocleidomastoid part. There were a few slides about that. I'll just rush through that if you want to. See, before the sternocleidomastoid, we have just done fascia and skin, not much. I'll just show. I'll just rush through this. Not much has been covered. Neck is, layered anatomy. So that we showed. And so the skin incisions, and the raising of the flap is very important. We have to take the subdermal plexus and the supply, the blood supply into consideration. And the watershed area we have shown with the facial artery, the occipital artery, the superior thyroid artery, the transverse cervical artery providing various branches. So this is the watershed area. And then the platysma, which is very important when we all neck surgeries wherever possible, unless it is involved, we always raise the subplatysmal flap so as to minimize the skin necrosis and wound breakdown, because it is the blood supply is associated with it. Then the platysma function, then cervical fascia, very, very important structure in, compartmentalizing the various structures within the neck. So you have the superficial layer, which is just beneath the skin and the subcutaneous tissue, contains platysma and the cutaneous nerves and superficial vessels and lymph nodes. Then you have deep cervical fascia, which is further divided into 3 layers. So one is the investing layer, or the superficial layer of deep cervical fascia, which encloses your trapezius, sternocleidomastoid, submandibular gland, parotid gland. Okay, and then you have the middle layer of the deep cervical fascia, which forms the visceral layer. That is the pretracheal fascia, which encircles the thyroid gland, the parathyroid gland, trachea, and esophagus. Then you have the prevertebral fascia, which is the deeper layer of the deep cervical fascia, which covers or forms a tubular sheath around the vertebral column and floor of the posterior triangle. Contains the sympathetic trunk, the phrenic nerve, the brachial plexus, okay, and prevertebral muscles. LR fascia is the anterior lamina of prevertebral fascia. The anterior layer of that prevertebral layer is the LR fascia. So these enclose, various potential spaces between them. Because it was already such a vast topic, I didn't cover the deep neck spaces and deep neck infections in this, but it's a very, very important topic. And the danger space and all those spaces, prevertebral space, retropharyngeal space. So all these spaces, potential spaces, are contained within these facial layers. So that is important. Carotid sheath is unique in that it derives the components from all 3 layers of deep cervical fascia: the investing layer, the middle layer, and the deep layer. So I hope that answers your question. And after that, we did the muscles and the sternocleidomastoid. So before that, you had asked. So any other question is there? Sure. Joel's triangle. Actually, I have not covered thyroidectomy in this per se, because there are so many other triangles which are associated with this thyroid surgeries. Bayer's triangle, Joel's triangle, and 2-3 more triangles are there. So with the diagram, it would be better to explain, but that is for basically identifying the superior part, the superior laryngeal nerve and the external laryngeal nerve. So that is, it was not a part of this, but I couldn't cover everything in this, because then it will become too vast. But thyroidectomy is a very, very important landmark, actually. Any other question? So if there are no questions,
Yeah, Dr. Rupa, I don't think there are any other questions.
yeah.
If we start covering all the surgeries and the applied anatomy in relation to surgeries, then it becomes really
Yeah, yes, ma'am, exactly.
difficult to
First, I
cover.
planned to do that, but like thyroidectomy per se, if you take all these triangles and all, if we explain and the applied anatomy, the recurrent laryngeal nerve in detail and everything, that becomes a class in itself. So
Yeah,
that
sure.
is why I, finally decided to give an overview of everything. because with that, and then later we can take each part. For example, neck dissection, we can and spinal accessory and all that can be covered in detail. Same with thyroidectomy, recurrent laryngeal nerve, the external internal laryngeal nerve. These can be covered in detail, like specific topic wise. Because if you
Yeah,
include
I
everything
think
in
thyroid
this,
surgeries we have discussed in a couple of classes.
yeah,
Neck dissection, I think it's still not been discussed, so
yeah,
that can be
because
discussed separately because
yeah,
again it is a vast
yeah,
topic.
thyroidectomy, parathyroid gland excision, and all are nice topics, but they are a complete topic in itself. So
Yeah.
that is
I think there's one more question. No. No. I would also request the students to join the class in time. I see that sometimes. So I think we can close the session
yes, ma'am.
if there are no more questions. Okay,
Yeah,
Mr.
thank you.
Navneet.
Yeah, thank you. Thank you very much, Professor Dr. Rupa Mehta, for the presentation. And thank you very much, Professor Dr. Nilima Gupta, for joining. And thank you, trainees and faculty members, for joining.
Thank you. Thank you.